With this, we will move to our next session, that is session 6 on hepatopathology rounds. And we are privileged to have our dedicated chairpersons to grace this session. Thank you so much. Please join me in welcoming on stage Dr. Ritambara Nada, Dr. Kalyan, Dr. Rohit Gupta, and Dr. Vijant Chandel.
So good afternoon, everybody. So now we have Dr. Sanjay Kakkar again. You all have seen him yesterday. He kind of, I would say, floored the hepatologist in hepatology forum. So today again, let's see. Today he'll show you much more what we can contribute to hepatology. So over to you, Sanjay.
Thank you everyone. Thank you to INASL again. So second pathology session in 2 days must be a record for a hepatology meeting. So the idea for this title and this kind of a session came during the discussions within the Hans Popper Hepatopathology Society in the US when we were planning a pathology session for the ASLD meeting. So the first such session happened last year, and it's going to be repeated in November in case you are going to the ASLD meeting this time. So I want this to be sort of a more informal session. And I may ask some questions. I would encourage you to raise your hands. And please free to ask any questions after each case scenario. You don't have to wait till the end for the questions. You know, we live in the age of AI. And so before this session, I asked ChatGPT to give me a pictorial representation of this title. So this is what it came up with. So I was very impressed by the complexity of the figure it generated, but it did not get the spelling of the pathologists and hepatologists right. So I asked it to correct the spelling. So it came up with an entirely new image. This time it got the hepatologist spelling right. But as you can see, pathology is difficult. The ChatGPT can't even get the spelling of pathologist right. So with this background, let's start with the first case. So I'm going to ask your feedback regarding these cases. So we have heard a lot about alcoholic liver disease in different aspects of it. So let's view it from a slightly different angle. So this was a 60-year-old who presented acutely with jaundice, abdominal pain, and fatigue, had modest elevation of transaminases. The bilirubin was more than 15, and the PEth alcohol test was positive, and all the other liver workup was negative. So in this clinical scenario, would you do a liver biopsy? Would anyone do a liver biopsy in this scenario? Yeah. It was a history of alcohol, and PEth alcohol test was positive. I don't remember the value, but it was clearly positive. And the history was there as well. Would anybody do a biopsy in this setting? So in contrast to many scenarios I showed yesterday, I did not expect even a single hand to go up in this situation.
There's one hand, two hands.
Oh, one hand?
Yeah, Dr. Rajiv Jalan is here.
Okay, nice. So I think you must have been the one taking care of this patient because the biopsy was done. Yeah. So the liver biopsy for alcoholic liver disease is not done in most situations. And this is some of the recommendations from the guidelines that the biopsy should be done when another etiology is suspected, alcohol consumption history is not certain, and so forth. And of course, as part of clinical trials. So this biopsy was sent to our institution from outside. So I really don't have a good answer of why the biopsy was done, but it was done. So, and this is what it shows. So you can see expanded portal areas with some ductal reaction, which is some non-specific findings. In addition, you can see a very prominent fat in the liver. I'll focus on the areas which show the fat, and this is the high power view. And this shows a contrast between this large droplet fat, macrovesicular fat, which is seen in alcohol, metabolic, and so many other etiologies. In contrast, look at these hepatocytes. They are large in size, but they don't have that typical cleared out appearance that you see in fat vacuoles. So they are almost like very small, almost foamy kind of an appearance, very small vesicles. Many of them are smaller than a nucleus, which has been suggested as one of the parameters to call this as microvesicular fat. So this appearance was seen in around half of the biopsy, and the remaining half showed a more typical macrovesicular fat. So this histologic appearance is actually very characteristic of the entity alcoholic foamy degeneration, which is a form of liver injury induced by alcohol, which is very, very specific in terms of its appearance. And as a contrast, you can see how a typical alcoholic hepatitis would look like. You can see typical balloon hepatocytes with Mallory hyaline and compare it to the small vesicles of fat that you see in acute alcoholic foamy degeneration. So what is the importance of this entity? This is just a table to compare the features that I've already shown you. In contrast to alcoholic foamy degeneration, alcoholic hepatitis tends to have much more inflammation, much more prominent ballooning like we saw, and fibrosis is typically much better established in alcoholic hepatitis, while fibrosis is typically either absent or mild in alcoholic foamy degeneration. So why is it important to distinguish between the two? So alcoholic foamy degeneration is uncommon, and I think it's really under-recognized even among pathologists as a type of alcoholic, histologic type of alcoholic injury. And in one Spanish study, it was estimated that 8% of patients who presented acutely and in what was thought to be alcoholic hepatitis actually had alcoholic foamy degeneration. And as you can see, long-term survival is close to 100% in alcoholic foamy degeneration compared to alcoholic hepatitis. So the prognosis is excellent in this. And this is a recent series of 9 cases that was published from King's College London, in which they emphasize that this differential diagnosis is very important in patients who present with clinical jaundice, as a rapid improvement after abstinence is seen in alcoholic foamy degeneration, and they do not need to be treated with steroids or other therapies. So since we don't see liver biopsies, or it's not done in most cases, is it possible to distinguish these two on clinical basis? So features that favor alcoholic foamy degeneration include young age, relatively shorter history of alcohol use. So alcohol foamy degeneration occurs because of like a binge of alcohol use that leads to mitochondrial dysfunction, impairment of fatty acid oxidation, and that's why you get the microvesicular fat, as opposed to alcoholic hepatitis, which typically results from extended or more chronic alcoholic use. It causes mitochondrial injury, and which manifests as hepatocellular ballooning, inflammation, and fibrosis. So lower bilirubin, WBC count tends to be lower or normal in alcoholic foamy degeneration. Ascites, varices, encephalopathy typically absent. Liver enzyme elevations may not be helpful. In fact, they are higher sometimes in alcoholic foamy degeneration. In one study, it was suggested that alcoholic foamy degeneration, the triglycerides, I think I made a mistake, it's more than 225, while it's lower in alcoholic. But a lot of these features that I've mentioned overlap, and the suggestion that triglycerides can be used to distinguish between these two was not really borne out by other studies. So at this point, I really don't know whether it is possible to make a diagnosis clinically of alcoholic foamy degeneration. Some transcriptome profiling studies have pointed out different gene expression in these two, but I don't think that is clinically relevant. So my question to you is, do you think it's important to distinguish? And how do you do it clinically if biopsies are not being done? I don't have the answer to that question. This is an uncommon entity, and I can say I've only seen 2 cases in the last 2 or 3 years, and maybe 1 case many years back. So it's uncommon. Whether it's uncommon because it's not biopsied or it's actually uncommon, I really can't say. So anybody would like to share their experience with alcohol foamy degeneration, whether it's clinically important? Yeah.
Don't know really clinical importance, but in last 3 or 4 years, we have seen 2 cases of in autopsy, obviously, of alcoholic foamy degeneration. And unfortunately, in both cases, fungal septicemia actually had taken the patients out. And rather than, we do not know what would have been if the AFD persisted. The other thing is, in both cases, we had done ultrastructural study, and in both cases, the mitochondrial structures were really, really damaged in both cases.
Yeah. So those are probably incidental findings at autopsy. So I think there are not any good answers available.
Sanjay, here, this
Yeah.
side. Kim.
Yes, I can hear your voice, but I can't see you.
Okay,
But go ahead.
you
Oh yeah,
said
I see you now.
You said
Yeah.
two cases you have seen. So will you interpret into percentage?
Percentage of microvesicular fat?
No.
No,
Out
the
of total
foamy
biopsy.
degeneration.
Yeah.
In how many cases you have seen it?
I have seen 3 cases.
Out of
Out
how
of
many?
how many?
I don't have a denominator,
I
but
think
I
that
can
would
tell
be
you 3
important,
cases.
isn't it?
So I think my answer will be more kind of a guess, but here you can see this was a systematic study. They found 8%. So maybe this is much better indication because they looked at 230 cases, and this was a biopsy study, and they found 8% on biopsy. So I would say that that is the best estimate available in the literature.
Sir, I have a comment.
Yeah.
Sir, the case we came across, and in the usual literature also, what they say is that alcoholic foamy degeneration tend to have very high elevation of AST and ALT.
Correct.
Typically, they say it's more than 500, but that is odd in your case, where the AST and ALT pattern was somewhere matching that of the alcoholic hepatitis.
Yeah, so you're correct. Statistically speaking, if you take group of alcoholic foamy degeneration and a group of alcoholic hepatitis, it's much higher and statistically significant. But as you can see, it doesn't work in individual cases. Any other comments?
So as you pointed out, the AFD is generally seen in younger population, right? The size of the liver generally probably wouldn't be shrunken. They will still have hepatomegaly, right? I think there are certain non-invasive flags that can pick up some telltale signs of AFD versus the real fibrotic alcohol-related hepatitis, right?
Yeah, I totally agree. And that's why I showed this list of features. And these can favor AFD. But at the same time, there's overlap with alcoholic hepatitis that in a given case, you may not be able to tell for sure.
So Sanjay, does it make a case for doing biopsies in alcoholic liver disease? Answer maybe to be taken up by the clinicians.
Yeah, I was hoping somebody to address that question.
Yeah.
So I think the answer will be that in a typical case of alcoholic hepatitis, you do not expect enzymes to be beyond 200, 300. But alcoholic foamy degeneration, as somebody pointed out, is one condition where you have enzymes which are more than 500. Now, that becomes an atypical thing for alcoholic hepatitis, and that possibly becomes an indication for liver biopsy. And as you said, the alcoholic foamy degeneration has better prognosis as compared to pure alcoholic hepatitis.
I think in one of the series that was published, it was suggested that the biopsy can be considered when this is suspected and let's say steroid therapy is being considered. In that case, it's better to do a biopsy if there are atypical features to confirm.
But my question would be, will it change the management?
Yeah, so the management, if you're considering, let's say, steroid treatment in a case thought to be alcoholic hepatitis, and it turned out to be alcoholic foamy degeneration, then you don't need to do it because almost 100% of patients improve just by stopping alcohol intake. They will improve very rapidly.
Sir, I have 2 points. One is it the AFD, which you mentioned, fat foamy degeneration, is it the same as microvesicular steatosis, or is it different from microvesicular steatosis? Because what we have studied is microvesicular steatosis is a diffuse kind of toxic injury, usually seen in drug-induced liver injury. It could be alcohol, which is due to mitochondrial damage. Same as alcoholic foamy degeneration. So is it synonymous with microvesicular steatosis? Secondly, the picture you showed us, that had some kind of sinusoidal fibrosis creeping in from the portal tract that had inflammation as well.
Yeah.
So I think that picture had features of alcoholic steatohepatitis as well. So should we diagnose it as concomitant alcoholic foamy degeneration with alcoholic steatohepatitis, or in isolation? What are the implications of diagnosing these both together? and in isolation?
Yeah, you're actually a very good point, your second point, and you're absolutely right that the case that I showed you had slightly atypical feature of alcoholic foamy degeneration in that there was background fibrosis. This patient had a longer history of alcohol intake and had background alcoholic hepatitis. It was not diffuse, but the fibrosis part was there. And that's why this was probably alcoholic foamy degeneration superimposed on a patient who had chronic alcohol use. And that has been well described to be there. And to your second question, microvesicular steatosis is a morphologic feature. Alcoholic foamy degeneration is an etiologic diagnosis. So you can get microvesicular steatosis in many different clinical settings. Alcoholic foamy degeneration is one of those settings. No, they are not synonymous. It's alcoholic foamy degeneration. Microvesicular steatosis is a feature of alcoholic foamy degeneration. It can be present in others. Alcoholic foamy degeneration is an entity, it's a diagnosis. Microvesicular fat is only a histologic feature, which can be present in many other entities as well. It's a feature, yes.
The morphological.
Correct. Correct. Okay. Okay, let's move on to the second case that I have for you. This is very similar to the one I showed yesterday, so I'll be relatively quick with it. 32-year-old with obesity and diabetes has elevations of transaminases and had autoantibodies, ANA and SMA were positive. And I already asked you, you had a lot of hands on this, so I assume you haven't changed your mind. And we saw that we know that autoantibodies can occur in steatotic liver disease. So here is what the liver biopsy showed. You can see that there is steatosis on low PAR. In addition, you have a prominent portal lymphocytic infiltrate, and this was present in several portal tracts. And a closer view showing you balloon hepatocytes. So there was steatohepatitis, but it was accompanied by a significant lymphoplasmacytic infiltrate in multiple portal tracts. There wasn't a very prominent interface activity, but mild interface activity was present in a minority of the portal tracts. So if we use simplified criteria for AIH in this case, that was one of the indications for the biopsy was to rule out AIH. And we assume that histology is one point here. So I'm not going to go into detail because I think you know this much better than I do. So 6 points is probable AIH if we add all these dependent based on the profile that we have. So a question I have for you is, do you use simplified score for the diagnosis of AIH? How many of you use simplified score? So a lot of you use simplified score. Okay. So I have a follow-up question for you. So if you see histology, compatible with AIH is 1 point. Typical of AIH, 2 points. So if you use simplified score, how do you determine the histology score? Do you ask the pathologist or just estimate it from the report? So if you really read the 2008 criteria, it mentions features like emperipolesis and rosettes. And more than 95%, close to 100% of pathology reports I have seen never mention those features. So if those features are not there, how do you determine whether histology score is 1 or 2? Yeah. Do you ask the pathologist or estimate from the report?
Mostly from report, I think.
In our center, pathologists give two statements. Either it is consistent or it is typical.
Okay.
Consistent is in between.
Yeah.
And
No, that's the way it should be. If you're trying to use it for AIH, you have the pathologist have to state. But in most cases, I've not seen that. So the recommendations of the histologic changes from the autoimmune hepatitis group have been updated now. So here's the publication for that. And it's a very detailed list of histologic features. But if I have to just simplify it, I would say that features like emperipolesis and rosettes are no longer considered important because it's been shown that they are neither sensitive nor specific. So they have been taken out. And what you have is either likely or possible, 2 points and 1 point. Likely just means it's a hepatitic picture which is at least of moderate intensity or has plasma cell clusters. And possible is it's a hepatitic picture, but it's mild. And if it's features of another disease, of course, it is a 0 point. So it's a relative, this is very simple, in a simplistic way that I'm presenting, but broadly speaking, This is what you're looking for from the pathology report to assign the histology points. So portal inflammation can be seen in steatotic liver disease once you exclude all the other etiologies. And it's well known that AIH scoring criteria can be misleading in steatotic liver disease, and you can get cases of likely IH because autoantibodies can be positive. So this other portal tracks, which I didn't show you earlier, showed florid bile duct lesion. There was CK7 positivity in the periportal area. So it was clearly a chronic cholestatic disease with diagnosis of primary biliary cholangitis and steatohepatitis. It turned out to be AMA positive as well. So let's say this was AMA negative. How many of you would do additional antibody testing for diagnosis of PBC? So it is being done here as like GP210 or other autoantibodies are being tested actively here. How many of you would do that? So it looks like a minority of people would do that. So this is what's been recommended by the AASLD guidelines as well. And even though the overall sensitivity is only 20 to 30% for these antibodies, this tends to be actually much higher in AMA negative PBC. So maybe around half, 40 to 50% of cases can be called as PBC more confidently if these autoantibodies are present. Okay. Last point I want to make about this case is that always keep Wilson's disease in mind. Copper stain is not reliable, but now we have a new tool in our armamentarium, which is the metallothionein stain, which has been reported to have high sensitivity and specificity. And we have recently started doing it. I don't have enough number of cases that I can tell you whether I have observed the same results as in the literature, but apparently it's very promising. Okay. So just a clarification of liver pathology vocabulary. I think these terms can be very confusing. And if you see terms like perforated septa, isolated collagen bundles, thin periportal spikes, approximation of central vein portal tracts, hepatic repair complex, incomplete septal fibrosis, incomplete septal cirrhosis, all of them basically are some form of fibrosis regression and remodeling of the liver architecture. And whenever you see these terms in the pathology report, that's what it means. And this is the image I showed you yesterday also. You can see the perforated septum, which is extremely thin, lacks ductular reaction or vascularity. So very typical for fibrosis regression. And you have approximation of the central vein and portal tract here. Can you let me know how much time I have? 10 more minutes?
10 more minutes.
Okay, good. Okay. So my next question, which has raised some controversy at least, I'm not sure whether it has raised that in India, is do you use the term portosinusoidal vascular disorder? I know that it used to be called NCPF when I was here, non-cirrhotic portal fibrosis. It's very common here. So I'm interested in knowing how many of you, pathology and hepatology, use the term PSVD for this condition. So I see a few hands are raised. So the reason I'm bringing this up is because after this term was proposed by the Waldig group, which is from Europe, there have been several publications which have pointed to the pitfalls of this terminology. So in the INASL guidelines on vascular disease of the liver, which were issued last year, they stated that PSVD is not a novel entity. So if you see the proposal publication of PSVD, the title says this is a novel entity. So they clearly stated it's not a novel entity. It's been well established for years. Both pathology and the clinical features are well known. And they recommended that they're not going to use the term PSVD. And they said existing terminology is what they will continue to use. And these are two very well-known liver pathology study groups. Both comprise an international group of hepatopathologists from multiple countries. And they have written commentaries which also point out some of the pitfalls of this terminology. And they have recommended it's better to provide the diagnosis based on the liver biopsy changes instead of using PSVD terminology, which can be potentially misleading. The other problem that has been pointed out is it's called portosinusoidal, but sometimes they're only portal changes. So you're causing something portosinusoidal disease when it's actually only portal disease. And I had conducted a survey of academic pathologists in the US, around 25 pathologists, and vast majority did not use the term. And they raised a lot of objections why they didn't use it. And one of the most important objection in my mind is very apparent if you scrutinize the criteria that were proposed. This is from the original publication. And I'll only focus on the histologic criteria. There are criteria for portal hypertension also. So they divided the criteria into specific and non-specific. And there were 3 specific criteria for PSVD: obliterative portal venopathy, nodular regenerative hyperplasia, and incomplete septal fibrosis. There was no evidence provided why these 3 were chosen, how are these specific. So they were just provided as specific criteria with absolutely no evidence. And if you peruse the literature, each one of these criteria does not meet the criteria or does not meet the threshold of being called specific. So just to give you an example, if you see portal vein changes, it has been reported even in normal livers, you may not have portal veins in a significant number of portal tracts. Sometimes you see dystrophic changes in portal tracts, in one study up to 30% of just normal biopsies. And here's a very nice study which was recently published, and they identified features which are of obliterative portal venopathy, which were considered specific for PSVD. They found them in a wide variety of chronic liver diseases, including steatohepatitis and chronic viral hepatitis, and almost every chronic hepatitis and even chronic biliary diseases in which there have been fibrosis or fibrosis regression. You can get a mix of these changes. So none of these criteria that were proposed as specific are actually really specific. So I personally prefer to use more morphologic changes. I would say portal vein changes or portal venopathy, and not use the term PSVD, which sort of gives the mistaken impression that I'm making a diagnosis of a specific entity. It's not an entity, it's just a set of morphologic features. It's like if I'm diagnosing hepatitis on the biopsy, the clinical picture has to be put together to call it autoimmune hepatitis. Otherwise, it could be any other hepatitis. It's the same here. Portal vein changes is what I can communicate to you. Now, whether it represents non-cirrhotic portal hypertension, or you can see portal vein changes as part of fibrosis regression in steatohepatitis, or any number of other conditions, that will depend on the overall clinical context. So I personally don't use that term. In fact, because of the objections raised, a new expert group has been formed from representatives from multiple societies, and by next year or so, I think there will be an alternative proposal. So I don't know how it will go in that meeting. So just to point out a few more terminologies that often come up in the liver pathology reports. So you may have seen terms like spotty necrosis or apoptosis, Councilman body, single cell necrosis. All of them basically refer to the presence of dying hepatocytes or dead hepatocytes, which are present singly or isolated in the biopsy. And when you see necrosis of groups of hepatocytes, that's what's called confluent necrosis. And depending on their distribution, a variety of other descriptors can be used. And since we are talking about confluent necrosis, I'm going to show you a case. And this, we've seen more than once this sort of error or this pitfall that I would like to point. This is a case which presented acutely. This was an autoimmune hepatitis case and had an acute presentation. And the biopsy was done, of course, to confirm the diagnosis and rule out other etiologies. And you can see a low power here. You can see it's nodular aggregates of hepatocytes, and in between you see this intense lymphoplasmacytic infiltrate. Now, because of this nodularity, this case was initially all diagnosed as being cirrhosis, AIH with cirrhosis, and having an acute on chronic presentation. But if you see the trichome carefully, you will realize that you can see dense staining in the portal tract, but the areas between these nodules are very lightly stained. So this is not really fibrosis, this is just necrosis. And the nodularity is not the result of fibrosis, but the result of necrosis. And you can also demonstrate that by elastic stains. You can see elastic fibers in the portal tract, that's normal, but you don't see any elastic fibers in the area of necrosis. In typical fibrous septa, you would see elastic fiber deposition maybe around 2 to 3 months after the necrosis has occurred. So here's a comparison of area of necrosis with no elastic fibers and a classic well-established fibrous septa with elastic fibers. So both trichrome and elastic stain can be very helpful in this setting to distinguish fibrosis versus necrosis. Now, in some cases who present with clinically with acute hepatitis, there is necrosis. There can be variable degree of collagen deposition in the areas of necrosis. So this is a similar case, the one that I showed you, but in contrast to no elastic collagen in the areas of necrosis, you can see there's scattered collagen here now, which was present in some areas of necrosis, but not in most areas of necrosis. So here, we often, at least the way I would do it is I would say that there is a patchy collagen in the areas of necrosis, and this could represent either evolving fibrosis, or less commonly, it's possible that fibrosis was there and there is superimposed necrosis. But in most instances, this was likely represent evolving fibrosis. So the question that I'm often asked then by hepatologists is like, what is the stage of fibrosis? At the
Dr. Kakar?
staging schemes,
Let's leave some time for discussion and keep this interactive.
yeah, I'm
If
going.
it's okay with you, yeah.
This is my last slide.
All right.
Yeah. So these staging schemes are not really devised for this kind of setting. So it's very difficult to really put a label or put a number in such cases where you have collagen deposition scattered within the areas of necrosis. So, all right, so we'll leave some time for your questions. I was perusing the schedule, and it's very interesting that there's a radiology session later. And I had only sent the hepatologist to Mars. They have sent the hepatologist all the way to Uranus. But after this session, after hearing from you, I think we are on the same planet. So we are fine. So open to questions now. Thank you.
Absolutely. Thank you. So I asked ChatGPT the same question, which planet is actually close to Earth, and it's actually not a single answer. It's 3 different answers depending on the celestial positions of Venus and Mars. Okay. So clearly, I mean, the reason why the phrase actually was coined is because of the lack of communication. And I urge that definitely we need to have better communication between the hepatologist and the pathologist. As a rule, I practice in Cleveland Clinic in Florida, and we always look at the liver biopsies ourselves with the pathologist. But again, if you're still inundated with a lot of the work that you have, at least pick up a phone and talk to your pathologist about what your question is to them so you can actually have better communication with them.
Any other questions?
Yeah. Mike 2?
Mike 2.
Thank you, Professor Kaka. I'm Uday Zakrai from CMC Vellore. In Vellore, we use for portal venopathy, we use a more clinical term and say non-cirrhotic, intrahepatic, portal hypertension. So NCIPH. So I was just wondering what your thoughts on that are.
Yeah, so that is a clinical diagnosis. So if I am looking at a case, it may or may not have portal hypertension. So I cannot call on biopsy portal hypertension because that's not a biopsy diagnosis. So on biopsy, if I see the portal vein changes, I'll communicate to you that I'm seeing portal venopathy or portal vein abnormalities, and this could be consistent with whatever term you prefer, non-cirrhotic, portal hypertension, or another, if there is portal hypertension. But in a subset of these cases, which are identified on biopsy, there is no clinical portal hypertension. And whether this will develop on follow-up, there are very few studies. A small percentage of these cases can develop or can progress to portal hypertension, but vast majority do not.
Thank you.
We're going to take one last question.
Yeah.
Sir, I'm Dr. Ashwin from PGA. Sir, I had during our liver biopsy round, we used to have discussion about this F1 fibrosis and its subclassification. Like F1A is mild pericellular or perisinusoidal fibrosis, F1B is moderate, and F1C is a periportal or portal fibrosis. So does this have any clinical significance, categorizing this into 3?
Yeah, well, as far as I understand, it does not, but the hepatologist can correct me if I'm wrong. So I think F1, within subcategories of F1 are more for research interest. And like sometimes in the pediatric setting, you see F1 see because it's periportal fibrosis, may not have the classic picture of fibrosis around the centrizonal areas. And when you're regression, the fibrosis is regressing, it may disappear from the central vein areas, but periportal areas it may persist. So you can see all kinds of variations, but I think it's a stage that depends. Within F1, as far as I know, it does not have any clinical significance.
About the regressing septa, how do you differentiate between a progressing septa versus a regressing septa?
Yeah, in general, in most cases you can. Sometimes it's more difficult. So the regressing septa tend to lack vascularity, lack ductular reaction, tend to be thin. And as I showed you, they tend to have perforation. It almost looks like somebody has put an acid on it and it's kind of dissolved. So that's the kind of appearance we expect. Progressive septa will be typically more thicker and have more vascularity and ductular reaction. But sometimes it may not be possible to tell.
And,
Thank you, sir.
more
Thank you.
healthier
Thank you,
hepatocytes
Dr.
close to
Sanjay.
the fibrosis.
Yes.
All right. Thank you all. Thank you, Dr.
Thank you.
Kakkar. This was a wonderful session.